So this is GI in a nutshell, sort of. After a veteran of many board exams, I just took my research in GI last year. Basically, most of the board exams in the internal medicine, they're going to give you a history. They're going to give you a case scenario. You'll have to usually have to recognize the disease, and then they probably won't ask you what the disease is. They'll then ask you what the treatment is. So you have to go 2 steps beyond. So what I'd like to, I have interspersed a couple of questions from the mix-up, but what I'd like to do is just cover a bunch of the general topics so you at least recognize kind of the disease process, all right? So we're going to start at the top and work our way down, and the first is the esophagus. With the esophagus, these are the likely diseases that you'll see. You'll need to know about dysphagia, and the first differentiation that you'll get that you need to sort of make, is this mechanical, is it a stricture? And we're going to be going through these individually, or is it a motility disorder? In terms of gastroesophageal reflux disease, most of the kinds of things that the kinds of questions that I've seen recently actually have to do with extraesophageal manifestations. So things like cough, asthma, those are the kinds of things that they're kind of focusing on right now. Eosinophilic esophagitis is something that you're likely to see because we're seeing much more of this, and I'll show you what the classic endoscopic picture is, and we'll talk about eosinophilic esophagitis. Barrett's esophagus and esophageal cancer hand in hand, and then Zenker's diverticulum, you could potentially get a history that would be suggestive of that entity. These would be the common kinds of things. Oops, we don't want to go there. So first of all, with dysphagia, this goes straight back to medical school. The motility disorders, the presentation you'll get is the patient will typically have as much trouble with liquids as solids. You might be given somebody who initially had as much trouble with liquids as solids and then starts acting, so it sounds much more initially like a motility disorder and then goes to a structural disorder, and that's okay because things like achalasia will start off as a motility disorder, then they'll get reflux, and then they'll get a stricture on top of that. So look at the way they initially presented when you're looking at dysphagia. Your motility disorders, the differential is going to essentially be achalasia, scleroderma, esophageal spasm. Those would be the most common kinds of things, and we're going to look at some of the motility patterns with those in a moment. Structural lesions, they're going to be solids first, then liquids. Your differential is going to be anything from a Schottky's ring, which would be an intermittent dysphagia, and is likely not to progress. It's likely just to be solid, intermittent bolus dysphagia. Whereas a stricture from damage, either gastroesophageal reflux disease or radiation, that would be a progressive. As it gets smaller and smaller, you'll initially have trouble with larger solids and then progressively have trouble with liquids as well as malignancy. Workup of the structural disorders, barium swallow is useful, but an upper endoscopy will allow you both diagnosis, allow you to biopsy, it'll allow you to treat with a dilation. So if you're given a choice, if endoscopy and barium swallow are both in your choices on a workup, you would choose the endoscopy because you're going to get a little bit more information about that. But either one would be appropriate. Endoscopic ultrasound is most helpful in the cases of malignancy, basically looking for spread into the chest. Okay? All right. Now, achalasia. The characteristics of achalasia are you're going to have an incomplete relaxation of the LES and then no peristalsis in the esophageal body. The LES may be hypertensive. On pathology, you would see ganglionic dropout at the lower esophageal sphincter. And again, these patients have increasing dysphagia to solids and liquids. They often will regurgitate food day later, 2 days later. The two esophageal kinds of situations where you would be regurgitating food would be achalasia and a Zenker's diverticulum, where you have a diverticulum in the neck. And those patients will often bring up whole food. Testing, as with any motility disorder, the manometry is really going to be diagnostic. especially for achalasia, because you will see these classic manometry findings. Upper endoscopy and barium swallow will basically help you see whether there's been any further damage. Treatment of achalasia, a low-risk patient would get a myotomy, so they would actually cut the fibers in the distal esophagus, a Heller myotomy, and this is done laparoscopically. A high-risk patient, we would inject botulinum toxin into the LES or do a dilation of the distal esophagus. The botulinum toxin therapy only lasts about 6 months, okay? But if you have like a 90-year-old, that's probably the preferable way to go. This just shows you the way of going down on the light. All right, so this is the typical this is a typical bird speak appearance. This is the esophagus. It's very dilated. It comes down into a little beak, and there's typically no gastric bubble. This is an endoscopy just showing all you see in these patients is just like full of food. It's like really revolting. But anyway, it's helpful in making the diagnosis. And then this is an example of an esophageal manometry study, and it shows essentially no peristalsis. Esophagitis. Moving on to esophagitis. Most commonly, patients will present with heartburn symptoms. They may have regurgitation, belching, or dysphagia. They usually do not have dysphagia. And as I said, one of the questions that I saw a lot on the GI boards, and I imagine that they're probably fairly similar, there are a number of less common extraesophageal symptoms or atypical reflux, and this typically would include hoarseness, asthma, chronic cough, sinusitis, bronchitis, erosion of dental enamel. So if you get a patient that maybe you're given a chronic cough and erosion of dental enamel, you should be thinking about extraesophageal symptoms of reflux. It's more common in males. It increases with age, and the risk factors are anything that's going to increase intra-abdominal pressure, as well as collagen vascular diseases. So obesity, pregnancy, smoking, collagen vascular diseases, alcohol, hiatal hernia, all will contribute to risk in terms of risk factors of esophagitis. All right. Now, the erosive esophagitis you see in about 10 to 40%, and it's these patients that get stricture formation, and the big complication, or one of the potential complications of esophagitis or continued reflux would be Barrett's esophagus, as well as less commonly these entities, so laryngeal cancer, aspiration pneumonia, pulmonary fibrosis, asthma. Empiric therapy can be used as a diagnostic test as long as you don't have, if you have just heartburn and you don't have dysphagia, you can just use a proton pump inhibitor as a diagnostic test and therapy. Upper endoscopy is good for looking at complications, but it's not diagnostic for reflux, because unless you have esophagitis, reflux esophagitis, the esophagus can look completely normal, yet the patient may have significant reflux. So if you're given a diagnostic testing strategy and the person is likely to just has heartburn and you're worried about reflux, you want to do a pH, some type of pH study. And the available pH studies would be a 24-hour pH probe where a probe is put into the esophagus and actual reflux events are measured, or there's now a little capsule that can be attached to the inside of the esophagus that also will measure pH, and it's wireless, so the person doesn't have a little strand sticking out of their nose for 24 hours. Again, barium is good for dysphagia, looking for strictures. It's not good for reflux. You can have a person that has refluxes 40% of the time, and it may not show up on a barium study. This shows you some examples. Let's see a way of getting this a little bit darker in the front.
It's on the computer.
It's on the over there on the computer?
Yeah.
Oh, thanks. So anyway, if endoscopic photos, The esophagus should normally be this color, nice and pink. If you start seeing white, you've got damage to the inside of the esophagus. And then if you see little white spots like that, and you know it's the esophagus, that would be consistent with Candida esophagitis. If you saw something like that and they told you it was a colon, it would look like pseudomembranous colitis, but that's Candida esophagitis. All right. It's not yet. Oh, something happened. You did something. That's a little bit better. Is it wanting to flip back on by itself spontaneously? All right. So that's a little bit better. And you can see this is all severe esophagitis. All right. Eosinophilic esophagitis, we've probably been seeing this in increasing frequency probably over the past 10 years, and it's really been recognized as a diagnostic entity over the past 5 years. And these patients get eosinophils infiltrating the esophagus. And this is a very classic endoscopic picture of all these little rings going up and down. And these patients' esophaguses are very, very rigid. If we try to dilate them, they tear very easily. We've had a couple of patients who presented with perforations just from eating, like getting a bone caught, and they presented with a perforation because these esophaguses or esophagi are so fragile. And it can be allergic or idiopathic. You should think about eosinophilic esophagitis, especially in a young male presenting with dysphagia. And you get these rings. If you biopsy them, they have greater than 15 eosinophils per high-powered field, and we treat it with swallowed fluticasone. And that would be, this is a very sort of well-defined defined entity that you might see. All right. Did I go too fast? So I did. All right. So the next thing in terms of the reflux and esophagitis would be that of Barrett's esophagus, and you know that it's a change in mucosa from squamous to a specialized columnar. It's a pre-malignant condition for adenocarcinoma. The risk of the cancer really overall is low, even though we think about adenocarcinoma with this, and I'll show you some of the esophageal cancer statistics. It occurs in about 10% of those who have weekly reflux. It may be asymptomatic. It does not spontaneously resolve. The progression with Barrett's is that you start out with no dysplasia to low-grade dysplasia to high-grade dysplasia and then ultimately to cancer. We are in the stage, a lot of flux here. If you are in the low-grade and high-grade cases of Barrett's, we used to just follow that until it turned into a cancer, and then we recommended surgery or some kind of ablation-type procedure. But now high-grade dysplasia is being ablated endoscopically more routinely to prevent this progression to cancer. If we look at adenocarcinoma and squamous cell carcinoma, they're actually fairly rare. I mean, if you're here at UNC with Dr. Shaheen, you think it's the most common thing on earth. But it's only about 12,000 per year. There's now an equal number. It used to be squamous was much, much more common than adeno. But if you're asked the number on incidence, squamous and adeno are about the same. Adenocarcinoma is more common in Caucasians. It's strongly associated with reflux symptoms and the development of Barrett's. Obesity is an increased risk factor. Squamous cell carcinoma we see more commonly in African Americans. It's more common in lower socioeconomic groups. It's associated with smoking. It's associated with ethanol. And if you have a patient that had a lye injury as a child, it is common as well. All right, so here's your first question of the day. So this is an 18-year-old man, a 3-day history of pain on swallowing, has no heartburn, regurgitation, or weight loss. He's been taking ibuprofen intermittently for 2 months for relief of elbow pain. On physical exam, his temperature is normal, normal pulse rates, normal blood pressure. His oropharyngeal exam is normal. There's no chest wall tenderness. So this, again, is history of pain on swallowing, so it would be odynophagia. And what
what would your choice be? Reflux disease, esophageal motility disorder, Zancker's diverticulum, pill-induced esophagitis, peptic ulcer disease. How many for reflux? 1, 2, 3?